Good afternoon, everyone. I'm Christy Koenig, the EMS Medical Director for the County of San Diego. Thank you so much for joining us for the next lecture in our series of evidence-based medicine presentations. April is National Child Abuse Prevention Month, and to honor this month today, we're delighted to welcome not one, but two experts to share their knowledge and experience with us during a presentation entitled Child Maltreatment Screening in the Pre-Hospital Setting. The first presenter, Makenzie Ferguson, is the Injury Prevention Educator for the Rady Children's Health Trauma Program. Her pediatric emergency and trauma nursing background focuses on injury prevention, education, and community outreach. She collaborates with EMS, schools, and other local partners to deliver evidence-based safety programs with the goal to keep children safe through prevention, provider education, and community engagement. Joining her is Zaky, who has more than 20 years of experience as a pediatric emergency trauma and burn care nurse. She manages the adult and pediatric burn program at UC Irvine Health, where, by the way, Kim, I spent most of my academic career. Her experience includes establishing a pediatric-focused base station in Orange County, and her expertise includes improving pre-hospital pediatric readiness and implementation of safe transfer processes through education and program development. As you can see from the flyer, both of these women have an impressive number of credentials. We are so pleased to welcome Makenzie and Kim to educate us on the latest evidence for child maltreatment screening in the pre-hospital setting. Over to you, Makenzie.
Thank you. Morning, everyone. I just wanted to introduce Dr. Ted Heining, who's on here as well. He's our emergency department medical director. And then I believe Shelby Shelton is here or maybe joining us from our research team who helped a ton with this project. I'm just going to share my screen.
Thank you, Makenzie.
Oh, hi, Dr. Heining. Okay, can you guys see it okay? Great. We'll just jump right in. Our objectives today are to talk about the role of EMS in early identification of child maltreatment, review the development and implementation of the pre-hospital screening tool that we created, talk about our outcomes and impact, and then discuss future directions for scaling and integrating the pre-hospital screening tool across multiple EMS systems. And I'm going to hand it over to Kim just to do a brief overview of child maltreatment.
Thank you. So I just wanted to provide a quick overview of the types of abuse within the child maltreatment. First is neglect, which is a failure to provide food, clothing, or shelter. And what we often see as providers is there could be medical neglect, a delay in seeking medical care, or supervisory neglect. And that's the most common type of abuse, accounting for approximately 70% of all cases that are identified and reported. Second is emotional abuse, which is the psychological or emotional impact or injury to the victim or child. Sexual abuse is often tied to human trafficking, and I know that has been a big topic coming to EDs and pre-hospital. It's usually vague signs and symptoms, and it accounts for about 9% of the reported abuse. And then physical abuse is any harm or mistreatment. It accounts for approximately 16% of the maltreatment within the United States. And of note, victims that are brought in by EMS have a higher fatality rate than those that are brought in by private auto. In terms of abuse for non-accidental trauma or physical harm or maltreatment, it is estimated about 9 out of 1,000 children experience a type of non-accidental trauma within the year, affecting maybe 1,700-ish kids that result in death. And those at risk, usually the younger the child is, the more at risk they are for mortality. And males and African Americans experience a higher fatality rate. For kids, especially the little kiddos, they're vulnerable, they are unable to defend themselves, and depending on their age or developmental status, they are unable to communicate what's happening. And we do acknowledge that identifying can be difficult to recognize, identify, escalate, and report. So quickly, I wanted to review sentinel injuries. A sentinel injury is defined as a sometimes minor injury or a medically minor injury, such as bruises, small lacerations, or pattern injuries that serves as a warning sign or precursor to more severe physical abuse. There was a quality improvement effort that was led in 2015 by Ohio Children's. So they launched a quality improvement initiative with the goal to reduce the child abuse incidents by increasing their ability to identify sentinel injuries that often precede the physical abuse event. And their impact is within 2 years, they were able to increase the number of identified sentinel injuries, which then had an impact to decrease the re-injury rates. So they had noted that the mortality was higher in recurrent abuse, 25% versus 10%. And 1 in 3 of those patients, minors, had been seen by a medical provider right before, usually within weeks of the major event. Again, the goal was to reduce the rate of the re-injury, identify and intervene the first time. And the lessons learned, again, is most of these children had been seen by a medical provider proceeding up to the major event. 1 in 15 children returned within the 12 months, and less than 1 in 3 got the recommended workup initially. So just to recap, minor injuries can precede severe injuries, and these are known as sentinel injuries. 27% of abuse infants had a previous minor injury. Minor injuries, again, Makenzie will go into more detail, are usually bruising, could be an oral injury, or some type of patterned injury. And then the first injuries, again, sentinel events.
So that brings us to our tool, which we named the SHIELD tool. It doesn't actually stand for something, although people have asked if it's an acronym. I feel like we should come up with something. We just saw it as protectors of childhood, and that's one of our tools at CHALK. I also forgot to do a disclaimer that we are rated Children's Health of Orange County. I'm sure many of you know that we are merging with our San Diego campus. So just want to clarify that all of this took place in Orange County.
So a quick history of, am I calling it? I guess I'll call it CHALK.
You can call it CHALK.
It was CHALK. So in 2013, CHALK opened as a receiving center. So prior to that, they were not available to paramedic receiving centers. Those would go to a neighboring adult facility, and then if they required transfer. So most of their patients were direct admits. In 2013 is when they started to get ambulance traffic. In 2015, they were designated as a level 2 trauma center. And at this time, at the recommendation of ACS, is why don't we see if we can develop a pediatric dedicated base station? So there was a lot of prep and training, but in 2019, CHALK opened up as a dedicated pediatric base station. The radio nurses were trained in both adult and pediatric. So they were held to the same standard of every other base station in terms of what populations they would run, but primarily all the pediatric patient paramedic calls would go through CHALK base. They wanted to have a level of redundancy. So CHALK, if geographically, were kind of located more north, and then they designated Mission Hospital, which also has an inpatient CHALK floor, as the second pediatric base station. So they were a mixed adult and peds base station. And then there was a recognition of comprehensive children's emergency room centers. So before a lot of these changes, we did not have what's known as like EDAP or pediatric receiving centers. It was the thought of the county that every emergency room should be able to at least see, medically screen, stabilize, and then transfer out peds. And then we started to get into development of policies and destination criteria. So we had South County mission and then CHOC being recognized as comprehensive children's receiving. So a certain subpopulation of pediatric patients were then identified and designated to go there the first time. And as we were going through a lot of these policies, another responsibility that we had because we were a dedicated pediatric station is that we had access to a lot of the pre-hospital data. So we would do a lot of outcomes, just seeing the patterns and destinations and transports of the kids. And then through this, Makenzie, who were you the CCERC coordinator at the time? Mackenzie's held so many hats, I kind of lose track on the time frame, but essentially, we had an opportunity to see if we couldn't start recognizing and screening some of these children pre-hospital and look for signs of abuse. And then 2021, CHOC came up as a level 1 trauma center. So that's just the history of where this took place.
I want to give Kim a lot more props than she gave herself because opening up the base station was a big deal. I think there's only one other pediatric dedicated base station in the United States. Dr. Jaime can have some credit too, but I think that really helped improve the care of children by pre-hospital providers in our county. Okay, this is just a snapshot of last year's child abuse statistics in our county. From what I looked like, San Diego is about the same size. I think you guys have a slightly higher population. I don't know about your child abuse statistics, but I would assume they would be similar. There are about 25,000 child abuse reports in our county each year. 12,000 of those are first reports, and then about 40,000 are duplicate reports that the kids have had some type of report within a certain time period. The age ranges, majority are 6 to 12, but we know that children under 1 and children's aged 1 to 5 before they're in school usually tend to be more high at risk. And then if you look at the allegation types, neglect and physical are the top types, which is exactly what our screening tool screens for. During the time we were developing this, there was no type of screening tool used by our county agency, OCMS, or any outside EMS agencies that we were able to find. Some agencies had received child abuse education through CHOC Base. At the time, Kim and our trauma team were doing a lot of EMS outreach, but it was really dependent on who was willing to learn and who had time to talk about pediatrics and specifically child abuse. So nothing was really standardized. At that time, Dr. Heiming was also introducing us to the child abuse clinical decision support team tool. Sorry. So we were implementing that in our ER and improving our child abuse screening for our patients that came through as walk-ins or ambulance runs. And then our county trauma coalition was doing a child abuse needs assessment, and that was for EMS and also hospitals, our ERCs as well. And there's just a lot of people interested in learning more about child abuse. So we felt like it was a good thing to bring to the county. So why did we develop it? The ED screening revealed that there was a lot of missed opportunities in the pre-hospital setting. We also saw that EMS documentation often contained concerning findings, but we weren't clear if they had actually recognized it or they had escalated it through telling a nurse or reporting it because it wasn't documented. And then we just knew that there's challenges in pediatric pre-hospital care. It's known that they don't get a lot of training, especially with pediatrics, and it's something that generally they report that they're uncomfortable taking care of. So our goal was just to bridge the gap with some type of standardized EMS-friendly screening tool. This is kind of why we felt like screening by EMS makes sense. In 2019, we had 30,000 annual child abuse allegations, which means that CHOC makes about 60 to 80 reports a month, and of those, about 10% arrive by EMS. We have 6,500 annual pediatric EMS calls in Orange County, which gives us 6,500 opportunities to assess for and report abuse. The other unique thing about EMS is that they are evaluating children a lot of times in their home, so they get a better view than we do at the hospital. And they're also getting those initial interactions of parents during acute injury or illness. So why it matters in EMS is 1 in 7 children are victims of abuse or neglect in the US. They're mandated reporters as well, so they have the legal and ethical duty to recognize and report abuse. We know that their training is really limited, and we also know that universal screening tools have really been effective in the ED, but there's no known pre-hospital tool that we can identify. When we did our literature review, what we found was the ESCAPE tool was the most validated and tool that had been around the longest. The 10-4 Faces P is best for high-risk injuries. And then a lot of people recommend some type of multi-face screening so we're not missing kids and having the Swiss cheese effect. There's also a lot of reported gaps and barriers in the literature, mostly about poor recognition of child abuse. And then EMS face unique barriers, including lack of pediatric expertise, discomfort with child abuse. They work in a fast-paced environment, and then fear of being wrong. Also, we know that universal screening improves identification reporting. It improves outcomes for children and families, and then decreases the bias and disparities that we all have. And there's many organizations that endorse the use of universal screening, like ACS, ENA, AAP, all are listed here. And then I'll just show you guys the other tools that we found. So the ESCAPE tool, this is the one most widely used. Looks at is the history is consistent? Is there delay in care? Does the injury fit with the development level of the child? Is the behavior of the child and people caring for them appropriate? Looking at a head-to-toe examination, and then anything that makes you doubt the safety of the child. This is 10-4 Faces P, which you all may be familiar with, but basically looking at bruising patterns specifically for kids under 4. So we look at specific areas where bruising is concerning. So the torso, ears, neck, and then faces stands for frenulum, angle of the jaw, cheeks, eyelids, and conjunctiva. Especially we worry about bruising in any kid that's less than 4 months old. Any bruise anywhere is concerning because kids that don't cruise rarely bruise. And then any type of pattern bruising. And this is from Children's Hospital of Chicago. This is the tool that our hospital implemented, the clinical decision support tool. So it's done by the nurses who complete this. It looks at if the kid's able to cruise or walk. Are they verbal, nonverbal? Looking at delays in care, history. There's specifics that are based on age for looking at physical injuries. We look for poor supervision care, nourishment, or hygiene. And then there is any a blank box the nurses can fill this out. Once this happens, it sends a notification to the provider that alerts them that we have a positive screening tool. It also shows up on our ED tracker to alert everyone. This is our logic model. We're happy to share this presentation. I know this is a lot, but basically shows all of our inputs, our activities, outputs. I have another slide showing how we implemented it, but I think the interesting thing here is the stakeholders and how many people were involved in putting this together, because it wasn't only our team, but we had to work with the county agency, the fire departments, our social workers, and child abuse physicians. So once we came up with this, we went with OCEMS to learn about if they were even going to let us do this and what the rules would be, which basically I'll show you the actual tool, but they only wanted us to have a couple of questions. So I think they put a max of 4 and they had to be yes or no questions. From there, we got participation from 3 local EMS agencies. We are very specific in this because we know that the departments can send the kids anywhere. So we picked ones that were closest to CHOC so that we would be the receiving center because we wanted to make sure we were able to easily track these kids. We did a pre-implementation paramedic survey to look at a few things. I have some slides, but basically want to know if they are actually willing to do this. We developed standardized online training. We provided some ongoing following up education. We did do a post-implementation survey that no one responded to. I think maybe we had a handful of people. It also was during COVID, and I think there was some fire, so a lot of them were sent out. So we realized that could also make a survey difficult to get responses to when they're responding to other types of emergencies. So what we ended up doing is a set of focus groups with the end users. And the goal of this pilot was really just to evaluate the feasibility, the usability, and the impact of a pre-hospital setting. So this is our tool in the PCR. It is available for any patient that is 18 years or younger. It is not a mandatory field, but they have something called validation built into the PCR. So certain agencies will require their medics to have a certain score. So this was handled by the agencies. They set what score they wanted it to be. That way the paramedics get the specific validation score for their charting. We did have a really good response rate. I can't remember off the top of my head what it was, but the majority of these were completed on every patient under 18. So the first questions are specifically looking at specific injuries based on age. So we separate it for kids less than a year and then over a year. And then we actually wrote out what they should be looking for and if the paramedics saw that. Next, we asked about the history being inconsistent with the injury or illness. We had some issues with this question, which we'll speak to later. We looked at was seeking help unnecessarily delayed. And then we just asked a general question about using their paramedic judgment. Do we have any findings that are reflecting poor supervision, care, nourishment, or hygiene? This is the medic questionnaire that we asked before rolling it out. So we wanted to get a background of how often they're actually caring for children that have suspected abuse. So most of them said 0, with a couple saying 1 to 2. So we do know it's that low frequency, high risk situation, or they're just not aware that they're actually interacting with these patients. They also showed a really low frequency of actually filing a report or talking to a nurse about filing. This looks at if they actually would like to have a screening tool built into the PCR, and we base it by their self-reported skill in recognizing child abuse and neglect. The good news was most people actually said yes, with a good amount undecided before even seeing it. Next, we asked what their behaviors were for when they suspect abuse or neglect. Majority of them said spoke with a nurse at the receiving center. However, we noted there was a gap in actual documentation of that, which we weren't able to find. The second was discussing with a colleague and then filing a report with the local child abuse reporting rules. Barriers, the biggest one was just fear of being wrong, which I think is universal. But second was just the lack of education on how to assess for abuse and neglect. And then concern over how to deal with family members, especially when they're in the back of the ambulance. That could be quite awkward, and maybe a barrier to them actually reporting or talking to their nurses about that. We asked about their level of comfort with reporting, and many of them said low or moderate. The most common themes were they've just never done it before. And then we asked again if they would like a short screening tool added to the PCR. Most have said yes. And then we asked their reasoning. Some people said that they're a dad, they know what to do already. A lot of people said they would like to have a packet or training to go along. And so we got a lot of mixed reviews, but we're glad that most of them said yes. The online training was on Target Solutions, which is the county's EMS training solution. So we just created a video that was a lecture. As far as content, we included a bunch of background statistics on child abuse, the benefits of how early identification saves lives. We reviewed all the county policies and reporting requirements, the types of abuse similar to what Kim went through. We talked about the screening tool and questions and gave examples of what to specifically look for, what the workflow was, how to file a child abuse report, and what happens actually after it's happened. And then as far as the system, we just did a countywide notifications to all MICNs. They were supposed to make base contact with our hospital, but we knew that sometimes there may be fallouts in the directions. So this is where their workflow. The screening tool is available for patients less than 18 years old. They complete the shield. If there's a positive, that initiates base contact per CCE or C policy. When they talk to the nurse on the radio, they're to report a positive shield. The goal was to make this not identifiable. We didn't want them to say anything about child abuse or raise suspicions with the families. And then once the MICN hears that we're there just to direct them to the closest CCRC if it's appropriate. Obviously, if there are other criteria that means that may need to be directed to another hospital, that would take priority. This is a lot, but this is our outcomes. So we looked at the patients that were transferred to our institution and the ones that actually were not transported to us. So we had 418 that were sent to CHOC. 50 of them were positive. We also looked at fidelity, which I'll go through, but looking at if the questions actually answered what we were hoping they would. So 20 were actually used appropriately. 10 of those patients had no type of child maltreatment workup, and then 10 had some type of child maltreatment workup initiated in the ER. So things we looked for were if there was a social work consult, and we ended up having to go through and specify because there's lots of reasons for social work consults. So we looked at ones that were specifically for concerns of abuse. We looked at if they got a skeletal survey, if we ended up filing in a car, or if they got a workup, including labs or imaging. And then we went through and looked at all of the negatives as well. I won't go through that, but we did learn some things from that as well. So overall, out of the 20 that were positive, 10 were appropriate, which we felt like was a win for us. Looking at the fidelity, looking at basically what we did is we had two nurses go through looking at the EMS narrative to see if they would have selected the same thing that the medic selected. Like for example, we looked at if they had any injuries. So the medics answered yes, where we said 0 actually met criteria. For the older kids, they were a little bit more accurate, but we really had a low N for physical abuse. There weren't that many cases. For their judgments, we felt like 19 out of the 23 were appropriate. Delays in care, a lot of them were also appropriate, which was interesting because originally our child abuse physician didn't think medics would be able to accurately understand when a delay in care is actually a delay. So they did a good job with this question. And then our biggest issue was this question. So is the history inconsistent with the injury or illness? Because of the double negative, a lot of people were confused and answered it incorrectly. So this was one of the adjustments we had to make, and we'll show you the next iteration of the tool in a little bit. From the focus group, we did, I think, about 4 to 6 focus groups, each with 1 or 2 EMS crews, and we had someone from our research team complete those. We looked at a few different things. So one of the complaints we got was making it base contact or not. We know a lot of medics feel like it can be cumbersome to make base contact. So there were a few positive remarks of making base contact. They felt like it makes the process a little quicker, so the hospital is able to get the team ready. There were some negatives as well, mostly talking about having to take their interaction away from the patient more. And they felt like they could maybe do that done with ALS, no contact, especially if they're already going to CHOC. They felt there were barriers to making base contact. They wouldn't want to take, let's see, they wouldn't want to do a take away from the parents just in case it's not abusive. So those would be those false positives. And then they also said that there's always going to be people in an earshot hearing them talking. So that could be a barrier of fear of people hearing and asking what they're actually saying. As far as the integration of the screening tool, they said it's pretty easy to use. It just fires up automatically, and they just read through the questions and answer them. They are really short. It pops up red, so it triggers us to think about it. It's super easy, super streamlined. As far as improvements, they wanted it to just make it easier as long as it pops up. There's a little box. They wanted an NA question, which we talked about, but we are afraid that they may not actually do any type of screening if NA is an option because they should be assessing these kiddos. And then when looking at the impact on the screening tool, a lot of them had positive things to say. So even if we only catch one kid, then that's a positive thing. And we kind of felt the same way. And then lastly, looking at the question regarding their paramedic judgment, they really like having that option, being able to use their judgment when things don't quite fit in a box. Okay, so future direction, and Dr. Haiming, feel free to speak up. But what we did is we took our study, we showed it to our child abuse physicians, and they made a bunch of edits. And then Dr. Haiming worked with a group of national experts to rework the tool for a much larger audience. So this is the tool now. It's available on EMSC. So it's called Doesn't Match. And our next goal would be to take this and change it into the screening tool and do a multi-phase study. So it uses a lot of the 10-4 faces P and some of the questions that we asked as well.
Yeah, thank you, Makenzie. I'm sorry, my video camera's not working. I usually like to see myself speak like most people. Sorry about that. Yeah, we had a group meeting with some EMSC leaders out of Colorado, Dr. Adelgeis, as well as Dr. Pierce, the developer of 10-4 Faces from Children's Luries in Chicago, and multiple other members who created the 4 questions you can see in the middle of this educational pamphlet. And it's truly just educational, but we are interested in trying to implement this in our county to replace the SHIELD tool that we had used previously.
So next goal would be to have at least 2 other sites in the county to enroll in a multi-site protocol. We want to look at how it's implemented in different system types. We know that not all EMS systems are the same. Looking at training education of the tool, the use of it, and the detection ability, and then also bridging the gap of the communication between EMS providers and ED clinicians, as well as the documentation that's still lacking. So in summary, EMS is uniquely positioned to identify early signs of child maltreatment. We know that standardized screening improves recognition and reporting. The SHIELD tool, it was feasible to implement, and I will say I believe we got good outcomes. Workflow integration and simplicity are really critical for adoption by EMS providers. And future direction includes some type of multi-site study to evaluate across diverse EMS systems. Lastly, every EMS encounter is an opportunity to identify and protect a child at risk. Okay, and we have finished a little early, so we thought we'd open it to open discussions or any questions that you may have.
Wonderful. I have lots of questions. But first, I want to say how impressed I am that you have a word that's not an acronym, but I couldn't help myself. I put it in the chat, some options if you
yay!
an acronym. It could be
Thank you.
Sentinel, history, inconsistent, examination, lesions, and documentation. And there's some other options there, but we do love acronyms in EMS.
We do.
So there you go. But wonderful, very important presentation. Before I ask my questions, let me open it up to the group. Please go ahead and put any questions in the chat or raise your hand or come off mute and just speak. This is our chance to stump the experts, and thanks for bringing the rest of your team along too. That's really great. So let me see. I don't see any questions in the chat. Let me see if I can find any raised hands. Again, if you want to just come off mute and ask questions, that's fine too.
Someone asked how many EMS agencies participated. We had 3 total. One was a lot larger than the 2 smaller ones.
Thank you. Yeah, and one of the questions I had actually was, were you coordinating with EMSC? And Dr. Hemming answered that in part, but not really for the state of California, as far as I heard. Do you have any more comments on how this fits into the EMSC program overall?
With the initial SHIELD study and implementation, we had not, but that is a goal to work with EMSC in California, as well as these other states in Colorado, Kentucky, and in Georgia, to try to do a larger implementation for proof of concept, and in order to roll it out to everybody.
Wonderful. And I think the timing is really good with the new specialty regulations coming into play very soon, and EMSC being included. I see a question. Do you find the survey/score useful to apply to all trauma patients or I'm sorry, all patients or just trauma related cases?
So we really didn't have a lot of physical abuse cases. Majority of them were actually neglect cases. We were surprised because I thought having the physical abuse things to look out for would be the most helpful, but there weren't too many. I think there was maybe a handful.
Yeah, that doesn't surprise me, but great question. Anybody else have comments on that before we move to other questions? Okay, one question I always have in these cases are, what are the reporting requirements for EMS clinicians? And if the EMS, for example, paramedic makes a report, and then at the receiving center, say one of the nurses makes a report, but the information is contradictory, the story is different, as often happens, does that hurt the medical legal case in terms of prosecution of the offender?
That is a great question. I think our child abuse physicians would have a better idea of how to answer it. I will say we made sure, based on their recommendation, that the screening tool was not put into the PCR. So it wasn't technically in the PCR, and it didn't get transferred to our electronic health record specifically for that reason. So what we did is we ran a report on the back end to get all of this data.
Yeah, OCMS has a policy 333.3 that when there's two people present and jointly have knowledge of suspected instance of child abuse, and there's agreement among them, that one member may do a single report, and that's after they have mutual agreement. And so the idea would be that after the paramedic discusses with the nurse or physician at the facility, that the facility would then take it on.
So let me say that in a slightly different way and see if I've captured it correctly. The paramedic who observed the suspicious case would be responsible to make sure that a report is filed, but somebody else could file it, like the receiving nurse, if they agree on what to put into the report. Is that correct?
Correct. I guess if there's mutual agreement to file when they get to the facility, then the person filing it would have, would put in whatever information was given to them by the paramedic.
And presumably the paramedic would need to also document that that happened in order to fulfill the suspected child abuse requirement. Would that be correct?
Correct.
Okay. What about other children in the same household and their risk? How do you manage that situation?
That's a good question. Some we've discussed but haven't had a good solution for, especially for cases of domestic abuse, because there's no PCR created for them. So unless that patient is the patient, then there's no way to document anything for them.
Any other thoughts on that question?
I think the bigger concern for us was those patients or caregivers who are trying to sign out AMA, and we made it as a part of the same policy. Contact with the base station was required for those individuals.
That was actually my next question. What do you do as an EMS professional if you see a sentinel injury, but the patient is not transported? What can you do? So it sounds like your answer is contact the base, and then how is that followed up? Does the base contact the county child protective services, or how does the loop get closed on that?
Normally, the mobile intensive nurse would give guidance. First, it's documentation, but also, a suggestion of escalation. We recommend calling the police to be at scene, getting information. And then I can speak individually. I know that I have escalated if I'm doing reviews for non-transported or, AMAs, that I would escalate through up to the county if I had a legitimate concern for follow-up.
Thank you. Any other comments or thoughts?
Initially, one of the nurses that was helping with this project would actually reach out to the EMS providers or their EMS managers, because we saw that there were some that were actually positive that weren't transported or were AMAs and somehow didn't make base contact. So there was a handful of those. So she would individually follow with those. And I will say, I do think they got better at actually reporting instead of waiting to get a phone call from Shelley. It was labor intensive, I will say, to review all of those.
Very good. And I heard you say, as far as you know, there's only one pediatric focused base in the rest of the US. There's a mission in Orange County, I heard, does adult and pediatric, but only one other that's solely pediatric focused. Is that correct?
Correct.
When I was opening the base, I was trying to find any mentors of who opened. Like, you're changing a culture, you're dealing with a very subspecialized group of, patient population. So, just trying to determine best, because you go from nothing to you're open 24/7 as a base. So I had a hard time trying to find other colleagues that could maybe walk me through it. But at the time before CHOC came up, pediatrics were run by every base. So as we know, the volume is low, and that just made the volume even lower. So being able to dedicate a base to these children and the calls, it was a learning process, but also we were able to get so much data and look at a lot of charts to see how we can help support EMS to improve overall childcare. So like implementing a PAT, being able to put in what a PAT is, select normal, abnormal, just to help with, assessments, and then, kind of stratifying out where patients should go, right place, first time. So if there's more, I would love to meet some other ones, but I can't, it's really hard to find, especially on the West Coast.
And would you say that you have excess capacity at the base that you have?
Say that one more time.
Would you say that you have excess capacity? Could you manage more calls? And you'll see where I'm going with this in just a moment, if you say yes.
So
You said yes at one point.
Yeah.
And then what happened?
I know. So initially, when we were proposed the idea of a pediatric specific base, they estimated 1 to 2 calls a day. But then after, looking at the data, changing to policy, I don't know since I've left, I don't know what the current call volume is, but when I was leaving, we were up to 10 to 14 calls. So probably an average of 8 a day. We actually moved up in terms of busyness over one adult base. So the calls are out there. I think we found them looking at some of the non-transported.
Yeah, but I think probably the major cost is to have the infrastructure that can support 24/7 responses, and that the marginal addition of a few extra cases might not cost that much more, depending on how you have it set up. So where I'm going with this is, have you discussed the potential to have a model, something like a poison control center? It's a little bit different than what you're doing, because a poison control center doesn't have the authority to give medical oversight, medical direction to the paramedics, just more advice. But it sounds like what you created is so unique and so needed that perhaps expanding the model so people could have access to your unique expertise might make sense in some way.
The place to start is Radio San Diego, Kim. Yeah.
Yeah, I think throughout this whole thing, just it's so beneficial for this population. So if anybody is willing to replicate or wanting to do something more to focus on this population, I'm happy to meet up and go from there.
Any other questions? Thank you, Dr. Hemming, for putting the information in the chat. We'll be sure to capture that and share it with our teams. Anybody else have questions or comments? I don't see any in the chat. If you want to just come off mute, we've got more than 50 people at this meeting here, and ask your question, go ahead and do that.
Hi, this is Adolfo Martin. I hope you can hear me okay. I just wanted to say thank you so much for sharing this really great tool, and hope that it can be replicated by all the pre-hospital agencies and emergency departments in the state of California and to the nation. Thank you.
Thank you.
All right, well, just to be clear, I was not suggesting chalk, I'm sorry, a pediatric base in our county. I was suggesting a resource
Yeah.
outside of our county
Yeah.
for other people to use. So just so nobody gets confused about that.
That's how rumors get started.
Again,
Yeah.
similar to the Poison Control Center model,
Mhm.
would be rather interesting. Anybody else have questions or comments? Do the speakers have anything additional that you'd like to add?
Well, just thank you for this opportunity to share.
Well, it's a really important topic, and it's perfect for complementing this month, and we appreciate your expertise, and thank you very, very much for joining us today.
Thank you, and thank you for coming up with our new acronym for SHIELD.
All right, thanks everybody. We'll go ahead and close the session right now, and we will reconvene again at 1 p.m. Thank you very much.